third annual Heart Expo. Kind of accumulate what we know about all that we offer and what we can teach the public about heart disease.
The mitral valve is between the left atrial and here the left ventricle. Here. Okay? You can see the leaflets of the mitral valve, then the cords of the mitral valve. Finally, you can see the papillary muscle in the left ventricle.
We show the one on peripheral disease first, and then I'll show you some quality awards. I'm going to go through this relatively quickly just to give you an introduction to some of the things that we do here at St. Pat's, and this is really a team effort from cardiologists, myself and others, radiologists, especially 2 or 3 of them who are interventional radiologists, our surgeons, Dr. Maxwell, Jairo, and Tata. And actually we also involve several of the neurologists in town to work with us as well, and I think Dr. Maddox will talk a little bit more about that. In terms of what is peripheral vascular disease, you'll hear the term PVD a lot thrown around. It involves everything outside of the heart, essentially, in terms of your arteries and veins, which is a large amount of territory. So at the level of the neck, we have the carotid arteries. At the level of the veins, we have problems from the veins in your arm, like this young man I was telling you about, to the veins in your legs where you get blood clots, kidney arteries, and we'll talk a minute about that, and then legs. Okay, in terms of symptoms, some of these organ systems have easily recognized symptoms, sometimes it's not. And much of what we do as physicians is try to separate out what the symptoms that someone might come in with are due to. In terms of carotid arteries, everyone knows, of course, about strokes. And I believe a few years ago I talked about treatments for some of these stroke problems. Transient ischemic attack, or TIA, which some of you may have heard of, is some people call it a mini stroke, which is really just stroke-like symptoms that last less than 24 hours, but are very bad in that they herald a likely full-blown stroke shortly thereafter. Some of you may have heard about Ariel Sharon in Israel, and he had a TIA, which, as most people know, didn't end well. My partner will talk about that in a little bit. Kidney artery problems can lead to, or blockages in the kidney arteries cause loss of kidney function, which can be temporary, or if the kidney artery closes, ends up with, of course, no function of the kidneys. You do have 2, but if it affects both kidneys, it can eventually cause people to go on dialysis, which is about 1/4 of patients. It is also the most common cause, when we find one, of severe high blood pressure. Now, having said that, it's only in about 5% of patients. Most blood pressure we never find the cause. Claudication, just Latin for pain with walking, and we'll be looking at a patient later this morning who has this problem, pain with his walking, and it's due to lack of oxygen caused by blockages in the leg arteries. Again, the first step is to do some blood pressure measurements in your legs and compare them to your arms. There are groups that come around Missoula and elsewhere that do this for free, and then refer you on to a physician if those numbers are not normal. And there's ultrasound and CAT scans, progressively more invasive. Blood clots in the legs have received a lot of press in the public literature. They can be very difficult to diagnose or very simple. I mean, the easiest thing is when someone comes in with a swollen, hot, painful leg after surgery, but it has the gamut of almost silence, just causing fatal blood clots as well. It is a cause of stroke, and they'll go through that in a little bit by my partner, Dr. Maddox, who helps fix those things. Aneurysms in the belly. Interestingly, Medicare just started paying for screening abdominal ultrasounds for aneurysms once in males over the age of 65. But also there can be aneurysms or dissection or tearing of the aorta in the chest. These are very difficult to deal with. recently, one of our surgeons, Dr. Iro, has been trained in a new technique to fix those without having major surgery. We'll be the first place in the state to be doing that. In terms of treatments, carotid arteries can now have either stents or surgery to repair them. The program here, which I went through a few years ago, has been going on about 3 years, and we've done 75 procedures, of which the mortality and stroke rate combined is 2.5%, which is half of the national average. These are all in high-risk patients up until recently, when we are now participating in a trial of the average or low-risk patient, and working with our surgeons, Drs. Jairo and Tada, and myself, we are in a national trial sponsored by the National Institute of Health to see which might be better, or are they the same. We are the only program in Montana which has full Medicare coverage due to our record and our research trials. Kidney arteries can be fixed with balloons and stents. Not usually surgery anymore. It's really rarely done. We have over 150 cases now with no major complications. Let's skip through this in the interest of time. Finally, leg arteries. There are lots of treatments depending on what the problem is. There can be balloons, stents, there's cutting tools. We have a multidisciplinary team which works with patients who have severe problems with ulcers in their legs and trying to get them healed. There is a full clinic here. It's the only one in the region, staffed by all these different specialties. And we recently purchased, as of the last week in December, a new $1.5 million cath lab, which is specifically designed to work on treatments for peripheral vascular disease, especially leg problems. And I believe Dr. Maddox will give you a little idea of what that can do. We have an aneurysm stent program here in Western Montana that is the largest in the region, and we have 2 people doing every case, an interventionalist, either radiologist or cardiologist, and a surgeon with them. It is amazing to see people go home the following morning, some of them that night. I see a few people here in the audience who've had this shaking their head, and they I think they can attest to some of their friends who are in the hospital for a week and don't feel good for 2 months, compared to eating dinner that night and home the next morning. Okay, and basically, if you want to see some of the national surveys as in terms of how we rank, you can get on various websites. I think more and more people are familiar with using the internet to look for rankings, and we'll talk a little bit more about that in a minute.
It's a pleasure being here, and thank you for spending your Saturday morning with us. It certainly means a lot to us to have you here. And this is my first time at the Heart Expo, and it is reminiscent of some of the things that you see in the large academic centers in places like Missoula, Montana. It's really quite a feat to put this together. I'm going to give 2 talks back to back, and Mark may interrupt us because he's going to have a case that he's going to do, and we're going to go live from the cath lab and kind of show you some of the stuff that we do up there. My first talk is about closing a hole in the heart, and then I'm going to move on and talk about imaging techniques in the cath lab and some of the new things that we're doing, some things that I was involved in at the University of Colorado, and it's quite timely because we're putting in new cath labs. Closing a hole in the heart, what we call percutaneous PFO closure, and I'll define those things. Just one disclosure on investigator disclosure, one clinical trial, which is a trial for closing these holes as part of research protocol. Now I'm going to go through a couple of case presentations. First is a 31-year-old New England Patriots linebacker who was hospitalized after he developed left-sided numbness, blurred vision, and headache. This occurred about 3 weeks after winning his 3rd Super Bowl ring, which was February of 2005. It was Teddy Bruschi. His symptoms resolved within 24 hours of the TIA. A heart ultrasound or echocardiogram was performed, and it was found that he had a patent foramen ovale. No other reason for why this would have happened to him. He then underwent a non-surgical closure of this patent foramen ovale, or hole in his heart, with a catheter from the leg. He was placed on aspirin and a medicine called Plavix, which is like aspirin, for about 6 months, and then returned to professional football the following season. The second case is a 34-year-old commercial airline pilot who developed right-hand numbness, weakness, and loss of dexterity while he was descending his plane for landing. Apparently the plane had a malfunctioning automatic cabin pressure controller, so he was manually decompressing the cabin. Pretty scary. Had a cold and was performing what's called a Valsalva maneuver to pop his ears and when the event occurred. He safely landed the plane with the help of his co-pilot, thank goodness, and his symptoms quickly improved. However, several hours later, he noticed that his face was drooping on the right side, so he went to the hospital. He had what's called an echocardiogram with a bubble study, and this demonstrated a hole in his heart, a PFO, with shunting of blood only when he coughed or performed one of these Valsalva maneuvers. He also underwent closure of this PFO with a what's called a CardioSeal device, which I'll show you in a minute, and is now regained his pilot medical. The 77-year-old Prime Minister of Israel, Ariel Sharon, was hospitalized on December 18th. I'm sure all of you know this. And it was reported that he suffered a minor ischemic stroke. We'll talk about that. He had an extensive evaluation, we're sure. Per media reports, he had his only abnormality was the finding of a patent foramen ovale, or PFO, by echocardiogram. His only past medical history that's widely known is he had high blood pressure. He was placed on heparin injections with a planned closure of this hole in his heart with one of these devices. However, on the day before that, he bled into his brain and had significant worsening of his clinical status. Today, there's ongoing controversy in the medical community as to whether or not PFO was the cause of Mr. Sharon's stroke or whether his medical treatment was appropriate. So what in the world is a PFO? There's some basic anatomy. There are 4 chambers of the heart. There are the 2 top chambers called the atria, which hold blood. That's why, like the atria of your house, they do little more than act as holding chambers. Then there are 2 muscular ventricles that pump blood to the rest of the body. There is a normal opening between the right atria and the left atria that is there when we are born. The purpose of this is to allow blood to go across the PFO when we're in our mother's womb before we're born, because our lungs aren't functioning and we actually get all of our oxygenated blood from the placenta. When we are born and the doctor slaps us on the butt, we start crying, we take a deep breath, this spontaneously closes. And within 3 months, it tends to seal up, and certainly by 2 years, it is sealed. However, in 25% of the world's population, this doesn't occur. So 1 in 4 people have one of these patent foramen ovales. But in the majority of people, the PFO never causes a problem. However, in some people, it's thought that the PFO is related to stroke, and particularly if it's in association with something called an atrial septal aneurysm, that wall between the right and the left atria is very floppy. The PFO itself may not be the cause of stroke, but rather really a passageway for blood clots to pass from the venous circulation, such as in the legs, and then go to the arterial circulation and then to the brain. The primary underlying problem is most likely abnormal blood clotting, and there's some good data to support this. This is an example of an ultrasound with the left atrium and the right atrium. Here is what's called the intraatrial septum, this line right here, and the little PFO is this door opening with a blood clot going through, and this is a pathological specimen of it actually going through. Each year, over 1 million people suffer from stroke in the United States. There's 2 basic types of stroke. 80% of them are ischemic, meaning a blood clot goes to the brain. 20% are hemorrhagic. They may be a bleed, an aneurysm or something completely different, or high blood pressure. 20% of ischemic strokes are what are called cryptogenic, meaning there's really no common cause of stroke identified. There are things that we see a lot of in our business, and strokes from atrial fibrillation and carotid artery blockages are very, very common. And when we don't see all of these things, we tend to classify strokes as cryptogenic. There's a bit of a selection bias. 40 to 70% of patients with stroke will have a PFO. So there's a relationship there. It's higher than in the general population. So this yields about 100,000 people each year that in the U.S. that PFO may be the leading identifiable cause. Currently, medical therapy is the approved first-line treatment for stroke in patients with PFO. All therapies are aimed at preventing a recurrent stroke, or TIA. There are several ongoing research trials to determine whether this procedure of going up through the leg to close this PFO is as effective as medical therapy. We have data from numbers of studies and try and compare one study to the next to try and see which is better, and that data has been adequate for the FDA to give partial approval of this device closure, but not full approval. We need randomized clinical trials. So the FDA does allow us to close patients who've had recurrent strokes on medical therapy, or who are patients that are not candidates for Coumadin therapy. Surgical closure is also an option that's been done for quite some time now. Well, how do you diagnose a PFO? Probably the best way is to do a simple test. It's an echocardiogram, an ultrasound surface on the chest, and we inject little micro bubbles of saline and air. This is safe to do. It's a very safe test. But you can see here the right atrium, the left atrium. This big floppy septum is an atrial septal aneurysm. It doesn't normally move that much, and there's bubbles being seen over in the left side of the heart, and that is not normal. And this is a direct route to then have passage to the brain and other parts of the body. The two devices that are approved are the CardioSeal device, the Onklotzer device. This looks like two umbrellas connected together. They can fold over backwards and be put into a catheter. This is a nitinol disc that's been machined into one position, and it prefers to stay in that position, but can be stretched and put into a catheter. The catheter is then advanced up through a vein in the leg. We go across the PFO from the right atrium to the left atrium. This is all done over a wire, which is not shown here. We deploy the left atrial side of the device, pull it tight up against the wall, and deploy the right atrial side. And it closes the hole. And we use X-ray imaging sort of globally to figure out where we are, but there is a new imaging technique that we use called intracardiac echo, which is contained within the heart, and we use that to guide our therapy. About 80% of the time, at least, or more, we get total closure right immediately after placing the device, but it's really at about 6 months that we see the device that it grows into the wall of the heart and becomes part of the heart, and we have complete closure in greater than 95% of the cases at that time. We spend one night in the hospital, return to regular activities at 3 days, aspirin and Plavix for 6 months. Irregular activities unless you're a linebacker for the Patriots or something. Aspirin and Plavix for 6 months, and then aspirin for life, no Coumadin. Finally, I'd like to mention something about migraine and patent foraminal valley. This is an unproven thing. There's a lot of excitement in the medical community about this. Migraine headache is present in about 12% of the general population, meaning 1 in 10 people. Patients with PFO have been found to have a higher incidence of migraine headache. In one small study, and they're all small studies, there are large trials going on, 89 patients with PFO, or something called an atrial septal defect, had this procedure to close it. 42% also had a history of migraine headache, and of those with migraine headaches, 75% of those who had migraine with aura, where they see the classic C or scintillating lights, had complete resolution of their symptoms. 31% of patients without aura had resolution, and of the remaining 40% had significant improvement in their symptoms. So it's interesting, and there's a correlation, and it may be a beneficial therapy, but it's unproven. And PFO closure certainly is not a treatment for this, but the trials in the U.S. are going to be starting in 2 months, and we anticipate those to be completed in a year to a year and a half, maybe 2 years at the latest. The science behind this is absolutely fascinating, and if anyone wants to know more about that, I'd be happy to talk to them. This skill set, this way of doing things in the cath lab is novel. There are a bunch of new procedures that are coming down the pike. There are other things that can be treated and closed, and using these devices and other similar devices. So in the future, there's going to be a lot of non-invasive catheter-based treatments to the heart that may have traditionally belonged to the surgical realm. So now there are 2 types of interventional cardiologists, those that like to open things and those that like to close things. Thank you. Any questions before I move on? Okay. What I'm going to talk about next is new imaging techniques, and specifically new imaging techniques in the cardiac cath lab. And then my colleague, Dr. Alan Gapster, is going to talk about imaging, non-invasive imaging techniques that that are new, that may not have anything to do with the cardiac cath lab. So what are some new ways to image the heart in the cardiac cath lab? Briefly, this intracardiac echo that we use to guide these procedures to close things. There is a catheter that is quite small, and it's half as small as this wire on the microphone, that we can put up through the vein in the leg directly into the heart and use it to take pictures while we're working. This is going to revolutionize a lot of the things that we do in the cath lab. The advancement in heart procedures done non-surgically would undoubtedly be guided by intracardiac echo. Things from closures to maybe even injecting gene therapy or other things into infarct or heart attack areas. The catheter is very small. It is directional, and we're able to guide it and turn it. We then pass it up into the heart, and we are able to image different chambers of the heart and get incredible fidelity. We can count the numbers of puppet strings on the valves with this imaging. And here's an example of intracardiac echo, and we're pulling one of these closure devices here, tied up against the intraatrial septum, the right atrium, left atrium, and there it goes, clamping down and closing the hole. Switch gears really quick here. Coronary angiography. So we're going to talk about coronary disease and heart attacks and imaging treatments and stents and angioplasty, things that we do so frequently in the cath lab. Coronary artery disease is the most common fatal disease process in the industrialized world. It's more common than the top 14 other leading causes of death combined. Coronary angiography is one of the most commonly performed diagnostic procedures in the world. And in 1997, coronary angioplasty became the most common medical intervention in the world. In 2005, over 2 million coronary angioplasties were performed worldwide, and this is following an estimated increase of over 8% during the past decade. Now, coronary angiography, we use a X-ray based system, and this dates back many years. In 1958, Dr. Mason Soames invents coronary angiography, and ironically, he did this in a room filled with cigarette smoke. It's a very heavy smoker. And he inadvertently had his catheter slip into a coronary artery when he was doing another procedure, and they were off to the races. In 1967, they were doing x-ray pictures, but only front to back, while they were trying to look at the heart and other parts of the body. And then they had to position the patients, cradle them, prop them, move them underneath the camera, and then someone got the bright idea that you can actually move the camera and not the patient. In 1974, biplane imaging with two different cameras in two different ways, perpendicular to each other, was invented in 1976 to the present day. Up until just very recently, we have been doing angiography where we take multiple images at different angles, still frames, and what we call fixed views. But starting in April 2006, we're going to be installing a new cath lab, and it literally will be one of the world's most advanced cath labs. We'll be able to perform something called rotational angiography with a flat panel system. Everything's going to flat panels, PVs, cardiac cath labs, but they give very high fidelity images. We'll be able to rotate the camera. I'll show you some examples of that. And then feed these images through a computer and come up with a 3D model of the coronaries and make very accurate measurements. And we need to be accurate. Procedures in the cardiac cath lab are becoming increasingly more complex. Long gone are the days where we just did balloon angioplasty on a simple narrowing in one blockage and had the patient stay in the hospital for a couple of days. Now we're doing very high-risk blockages, high-risk patients, multiple vessels in the same setting, complex devices like diamond-tipped burrs that spin at 140,000 revolutions per minute, or per second. And these interventions are expensive. We need to be very exact in our placement of $3,000 drug-coated stents. And patients are coming back to the cath lab multiple times in their life as they live now with coronary artery disease. It's a lot of radiation exposure. It's a lot of contrast exposure to the patient. So we're pushing the envelope. We're measuring success in millimeters, and we need to be safe and precise. I mentioned traditional coronary angiograms really give a single picture of each injection of contrast. We step on the x-ray machine, we inject contrast, we take a picture at an angle, we move the camera to a different angle, take another one, inject more contrast, take a picture, and move on. So we use multiple different angles. And then part of our training as interventional and invasive cardiologists is to take all of these different still films, put them together, and in our mind, reconstruct what's really a three-dimensional structure known as the coronary artery tree. Additionally, the measurements made from two-dimensional images are not optimal. They can be inaccurate, and that's a known problem. Rotational coronary angiography takes we take the camera, we do a high-speed rotation of greater than 55 degrees per second around the patient during a single injection. So we're one injection, one step on radiation, and it translates into more information and significantly less contrast and radiation. So this would be a complete coronary angiogram using rotational angiography. Two different views of the left coronary artery and one view of the right coronary artery. And we're in the digital age, so we can just stop and look at each image as if it was one of those still frames. And we've got all of this information up front. With standard two-dimensional X-ray imaging, the coronary blockages can be hidden. Now these are 3D representations, but just to prove a point. And there is literally a window of opportunity. You can see that narrowing right there in the coronary. And if you're not exactly at that right angle, you're going to miss it because there's other arteries that are covering it up, and then you may be in a plane where it's coming right out at you. The blockages also aren't just simple and tubular and straight. They actually may be egg-shaped or oval-shaped, and there's a serious narrowing there that unless you're right at the exact angle, you're going to miss it. So rotational angiography is proven in research trials to decrease contrast and radiation exposure by up to 40%, decrease physician and staff exposure to radiation, and we're there too. In fact, some of these interventional cardiologists glow in the dark. There's so much radiation exposure. We've got to protect our staff. Better information obtains about 60 times the number of images compared to traditional angiography, improves the images compared that are then shared between hospitals and other medical centers, and minimizes the visual skills of the physician. But it is also a platform to create 3D images of the coronary arteries, which can aid angioplasty further and further decrease contrast and radiation exposure to patients. So we can take these 2D angiograms and make 3D reconstructions right there on the table as we're doing things, and use that information to guide our therapy. So, wow, that's cool. We've been doing 3D imaging of other things for quite some time, but unlike boring organs like the brain and the liver that don't move, the heart actually beats 82 times per minute or more, and it has been no small feat to come up with algorithms that accurately accurately reconstruct these in 3 dimensions. Well, the value of 3D is that we can simulate pictures which were not taken. We've made the 3D reconstruction, we can move the model any way we want without giving dye or radiation to the patient. We also can aid the doctor in measuring the length of blockages, the diameter of the vessel, to choose which kind of stents or size of devices we're going to place, and something that traditionally with 2D images has been less accurate. Data can then be exported to other imaging systems like a CAT scanner, and Dr. Gaps is going to talk about 3D CT. These are just a couple of examples of 3D reconstructions of the coronaries here. We can pull out segments, get a lot of information about different parts of the coronaries there. We can see a narrowing, stop it, measure the length of the area we want to treat very precisely. We can determine what the volume or cross-sectional area or diameter of that vessel is, and then choose the right stent, both in length and size, accurately. There's also computer assistance, which is helpful. And the computer can come on and say, hey genius, why don't you go in this view and try working here? Much better way of doing things. And we can move the model around and say, all right, this is the perfect angle for us to do our intervention, and I wouldn't have thought of that. And thank the computer for helping me to figure that out. There's really no limit to what we can reconstruct. This is an Omplotzer ASD device that's just this metal mesh wire that closes large holes in the heart, and we've reconstructed that. Very high fidelity. So finally, what's the future of rotational angiography in 3D? Well, we can hopefully enhance the quality and safety of angiography and interventions. We can optimize our approach during interventions when we're putting stents in and fixing things. We can hopefully do a better job of matching our equipment with patient's anatomy. We can research how these devices interact with the heart and the arteries. We can maybe integrate with other medical technologies such as CT. We can train, physicians can train with simulation. Flight simulators for interventional cardiologists, this already exists. It's based off of this technology. We can then test physicians for certification and say, if you want to be an interventional cardiologist, you need to have the skill sets to be able to do these. And the ABIM, or the American Board of Internal Medicine, is already underway doing this. This is going to happen. We can practice procedures immediately before we do them. This isn't something that is being done anywhere that I'm aware of, but it certainly is a concept out there that we can reconstruct a patient's coronary to say, wow, that looks really difficult. Let's just try it in a model before we attempt to even do it. And then finally, the ultimate thing would be to execute using robotics. And these are all data points that can be fed through a computer and we can steer wires and other things through them to fix complex problems. Thank you.
The story he told me is that his biggest problem is when he wants to walk 4 blocks to the park quickly with his young granddaughter. He has trouble when he gets to the park, and by the time they leave, he has to stop several times to get home, and that's been an issue for him. In Great Falls, he had an ultrasound suggesting a problem in the left leg. It's only his left calf that hurts when he walks. He also has some other issues that don't relate to his leg pains. So what we thought we'd do is show the pictures as we go along and explain what we're doing.
So you suspect that he has a blockage in his left leg artery from the tests that have been done so far?
Right. The ultrasound in Great Falls suggests in the mid-thigh a problem. And since the way the circulation works, if you have a problem in your thigh, usually the next place that is downstream is the calf muscles because they're so big, and they're the ones who will complain when there's not enough oxygen at that level. Let me just show you briefly here what we do is we've already given him some Novocaine. Did that hurt? No? No, he says not at all. He's a generous man. And then we put in this tube that, if you could show this, allows us to have access in and out of the artery without losing any blood. Todd, I don't know if you want to talk about the dilator, and then there's some.
We typically will put this is the same as for coronary angiography. How do we get access to the artery? And we put these sheaths in over a wire, as we do with so many things. Everything is over a wire, so we don't injure any vessels. And the dilator comes out, the wire comes out, and we're left with a tube or sheath that sits in there, and we're able to flush it with a sidearm and then put our catheters through that without having to poke people again and again. So it's a one-way valve, a doorway for us to get into the artery now without losing any blood.
Before I go further, I'd also like to introduce, we have over 30 years of experience here in this cath lab this morning. I have John here with me, who's been actually, I believe, a cath lab director in the state of Washington. Teresa, who is from the Blue Ponies of Havre, Montana, if we have anybody in the audience from there. And Mike Godwin is in the back helping us with the hemodynamics. In place, can you go live to the monitor? We have in place a catheter in the abdomen for the first picture, and this is live now. So the catheter is in the belly, and this will inject a whole bunch of iodine dye quickly to get a picture of the outline of the arteries. And this is what the catheter looks like. For the pig farmers in the audience, we actually call this a pigtail catheter. And it has a whole bunch of holes all along here, and then out the end of it to inject iodine dye all the way through it. Okay, so let's go live and get our first picture. Any questions, Tom?
Keep going.
Mr. Robertson's telling me how happy he has been with the courteousness of the people. Is that? So this picture inject a lot of contrast quickly, and we can outline the anatomy. Inject. All right. Todd, do you want to describe the anatomy of there?
He's injecting just below the renal arteries here. These are the kidney arteries coming off of the aorta. This is the aorta. We're in the belly area here. It then splits into two branches, the iliacs. And there's internal and external iliacs as we keep going down. And then now we're into the pelvis region where the femoral arteries this is left, this is right. It's backwards.
You're going to want to pull that down a little bit. So we're going to do the right leg, which probably will be normal. All right, ready? Okay, this may be some burning in your leg, won't be very much. Check.
Knee.
Okay, so let's replay it. Go ahead, you point out the anatomy.
So this is the common femoral. There's a bifurcation here, or a fork in the road for the deep and superficial femoral arteries that continue to go down and supply the rest of the leg, versus through the muscle here, called the adductor canal, and back behind the knee here, popliteal artery. And then there's a 3 forks in the road down here, which we're not going to see all that well as the guy diminishes the anterior tib, posterior tib, perineal artery. We use these names so we can communicate with each other and figure out where we are. Really, this is one long artery with segments that have different names.
Okay, we're going to go live.
I didn't see anything before.
No, I think it looks great. That's what his symptoms would indicate as well. So here we are live. We have a wire. Stay on that. And a catheter, a mammary artery catheter, which has a hook on the end. You can see now.
He's pulling it down to where the artery actually bifurcates or splits in the road. Remember when we saw the aorta and it kind of sits on there like a saddle.
Okay, so we'll do the left leg here. Ready? Check. Okay, let's see. All right. I'm gonna let you talk while I try to get a.
Mark has injected the left iliac here. The 100% blocked artery, no dye, reconstitutes down here. Keep playing that.
Oh, sorry.
Coming down. Dye flows nicely through here and that branch, but going down here, 100% blocked. And then right above the knee, what we call the popliteal fossa, there's dye that is reconstituted, and that's coming from other little branches that parallel that main artery. So we've got a long total blockage. Do you think that starts in the adductor canal, Mark?
I think it's above it.
Okay.
I'm not sure. We're gonna try to get a little better picture with the side injection.
Here you can see a wire we're putting down here. Again, everything in the vasculature is done over a wire. We put the wire down the head of our catheters. We then use that as a rail so that we don't damage any of the vessels. Same in the coronaries, same in the legs. It's all done that way.
Go back now to the other one. We're going to try to get a better look to see if it can even, whether this could be fixed with a balloon, because it's pretty long blockage. Let's go to 30 ileum. 30.
Frequently in the legs, we can't use stents, unlike the part where stents are always preferred in the leg, such as behind the knee or something where we're bending, we put these long metal stents in and it crushes them. So there are segments of that artery that are no stent zones.
Okay, so we're here on off-axis. Try to get a better picture. So go live. You can see, focus on there. The cameras here move various angles. And so we're going to go sideways and see if we can see if there's any place to put a wire and to cross that. Okay, go back to the... Okay, good. Check.
Pretty good run up.
Very good run-up.
Mark,
Yes.
would you remind us of the patient's symptoms and then tell us how this anatomically makes sense? Because I'm sitting in the audience and not everybody knows where the adductor canal is. But maybe you could tell us again his symptoms and why this anatomic lesion makes sense for his symptoms.
Good. Okay, that's a good question. I think Todd's done a good job of explaining the anatomy, but just to go over that for a second again, we go back to the top here. So this would be his groin, and there's his hip. If you could point out the hip there, Todd, femur, and then this would be halfway down his thigh. And this is the main artery supplying the circulation to the leg. The one that's branching on the right there is the deep femoral artery. Todd, if you want to show that. And really, nature's done a wonderful job of giving us a reserve. That artery really doesn't do very much. You can live without it, no problem if it closes. Where you really need it is this situation where the main artery, which is the one that's closed there, if you can show that, because it's closed, you now see this spider-like network of branches called collaterals. And we, all of us, surgeons and cardiologists, talk about this word collaterals, and you rarely see such a good example, if you can point that out, so that blood does get to the lower leg, but it's only going through these little tiny branches. And therefore it never has the same amount of oxygen of carrying ability that the regular artery has. And so it picks up the regular artery down here at the knee. And unfortunately, there will never be enough oxygen, but the next place that you're likely to find a pain is where you have the most muscle mass. So in the thigh, this artery here on the right can supply enough oxygen because it's pretty big. But down below the knee, there is no single artery supplying a normal amount of flow to this area. So the calf muscle is the one that will complain when you have a blockage in that area in the mid-thigh. So that's why he has pain when he walks more than a certain distance, or if he walks too fast. Even though the arteries down here are normal, and they really are normal in his calf, there's not ever going to be enough oxygen the way things are right now.
So his symptoms were of lower leg or calf cramping?
Correct.
And I saw on your slide that you said claudication was Latin for pain?
Pain with walking, I
I
believe,
think
or cramping with
it's
walking.
Latin for to limp, as in Claudius from Julius Caesar, who walked with a limp, I think.
I stand corrected.
Okay, but so anatomically, this lesion makes sense for his symptoms.
Absolutely.
All right.
Now, the question is, what's the best way to help him? I mean, he really would be active. He's a very active 80-year-old man. And at this point, I mean, as always, there are three options. There's medication, balloon, and surgery. And each, of course, has its advantages and disadvantages. There is no... Oh, I'm sorry, it's 69. I thought it was 79. Jim, forgive me. Well, no wonder you're so active. medications, stents or balloons, and surgery. Medications in the leg arteries have not been shown to be very effective. They can sometimes make a difference between someone who has only a 50-yard walking capability and they may get to 100 yards. Or they may have a non-healing ulcer on their foot and it may make the difference to allow it to heal. But in terms of getting a significant improvement, they don't do it. So then you're left with the options of balloons or surgery. In this case, this is a pretty long blockage. I don't know that it's obvious with this, but this would be probably a distance of a good 6 to 8 inches.
Why is that a problem, Mark? Is it that you can't get across, can't fix it, or that it will close again?
Actually, yes and yes. It's a good question. The number one problem would be, can it even be done? I'm not sure. We're going to try to go with the wire wall. I'm going to let Alan do his talk, but it does carry a higher risk of re-narrowing when the longer the blockage is. On the other hand, surgery is also a good option, but it does not last forever. And our surgeons tend to, actually most surgeons, tend to not want to operate in patients who do not have limb-threatening problems. So for just a problem with walking, they tend not to want to operate because of the risk of surgery and the fact that at 5 years, only about 70% of the grafts are open. So, other questions?
With the symptoms and the lack of oxygen to the leg, is there ever a blue discoloration of that extremity?
Yeah, you know, when patients first come in, and of course we don't have all this information, we take a history and a physical. And it's interesting trying to sort out whether the problem is a vein or an artery based on the physical exam and the history. If someone has pain in their leg, it can be either one. Blue discoloration of the extremity is typically a vein problem. When you have a lack of arterial circulation, at its most extreme, the leg is pale or white, and that's usually just before you lose your leg. But even before that, it's maybe a little reddish discoloration. So in his case, it wouldn't be blue. In someone who had really bad veins, those would be blue. Because they don't have much oxygen when the veins are bad.
Mark, how about if we let you go ahead and do your work, and we can field questions from the audience. Todd's still here, can answer the questions, because Todd also is involved in peripheral vascular disease. And then if you find something fascinating you want to show, feel free to interrupt us, Mark, and we'll get to Alan's talk too.
Great, thanks.
I just was curious if you use medication in conjunction with the angioplasty, does it help with restenosis in that area, or?
The question is whether we use medicine in conjunction with, I feel like Derek Springer. In conjunction with angioplasty to prevent it from narrowing again. And the answer to that is no. There have been no medicines that have prevented restenosis. Medicines on a stent have been worked very well to prevent restenosis in the heart arteries, and probably is also very, very beneficial in the leg arteries. And while the process of cholesterol buildup in the legs and in the heart and in the neck arteries is all similar, we're always surprised to find significant differences between those different vascular circulations and also how they react to our treatments that we give them. But I think the only medical therapy for preventing these things from blocking off again are the drug-coated stents, and they do a fantastic job at that. And at least in the coronary artery world, they have reduced the risk of the stent failing by less than 10%.
Colon circulation, is that something that we all have? Does it increase when we get a blockage? How does that work? Collateral circulation?
Not everybody has collaterals, and I think that if we figure out the reason why one person has collateral circulation versus the other, that would be close to Nobel Prize worthy. It really is something that's important when people have a heart attack. It's important comes on slowly and it narrows down slowly, that these new arteries will grow in. And we actually, as a medical community, have scientists have manufactured, synthesized the main stimulus to grow these new arteries, VEGF, and we tried to use it for treatments to give it to patients, but it causes blood vessels to grow everywhere, the eye and those sorts of things in animals. So it hasn't really panned out. But one of the biggest stimulus for VEGF is actually exercise. And exercise to the point where you get that claudication. And maybe in our patients with chronic heart problems that we're following very closely, to exercise to the point of getting just a little bit of chest pain and backing off. The chest pain and claudication are the same sort of things. Not everyone has chest pain, and that's not a general recommendation for people to do. That's a specific recommendation for a specific patient when we think that's a good idea. But that exercising to the point of claudication in the leg is probably one of the biggest stimulus to grow these new arteries. And that is a proven therapy for claudication.
Can I just show you one thing?
Yes.
We are working with a soft, I'm going to describe the live wire, and we're actually through the blockage. It took a while, but see how it's looped? That's in the artery itself. And we're going to move it down, and actually it looks like we may be able to get this. So I'm going to let you go back to...
So you looped this wire and just pushed it through?
Yeah, we first poked at it with the tip, but as you know, you poke too hard with these very soft wires and you go right through the artery. So we did it just a little bit poking with that so we could get through the first part, and then looped it so that it went smoothly down the remainder, and it looks like it's in the main vessel. I'm going to let you go back live. I just wanted to show you that, and we'll come back when we get some balloons out and so on.
Mark, I have one question for you, just a technical question. Does the size of the loop, or does your ability to drive a loop through that artery suggest that that lumen's going to be okay?
Yeah.
Any other information that makes you handicap this for us?
The loop is very important because if you can't do a loop, that means you're probably driving it through the wall around the actual artery itself. Usually when you can do a loop like this, these are very soft. That means you're moving through the middle of the artery. So that's why I like to loop it. It almost never goes outside the artery.
Great.
Remember, we're going blind right now. We can't see anything. We're just going back to the artery. Okay? Why don't you go back? Okay. We'll come back later.
We have another one.
And actually, we're going to go ahead. We did get through. So we're going to go ahead while Alan gets us talked. I'll show you the balloon we're about to put in.
Okay, Alan? You show us the balloon, Mark?
I'll just show you the balloon before we put it in. It's a long balloon and it goes over a wire. As you can see the wire coming out the tip.
So this is a balloon, not a stent?
Correct. Below the knee, or below the groin, you rarely stent. There's no study showing that stents work better than the balloon below the groin. Some studies showing it works less well. And we know we're in because we took a picture.
Do I show you that?
Yeah. So that's actually the catheter all the way through the blockage. We have to prove that it went through the blockage. So you can see the vessels now below the knee. That's the knee joint there.
That's the vessel we couldn't see before.
Right.
I think the patient's wife is here in the back row. Kim's sitting next to her, and she's able to watch as well. So that's encouraging news so far, Mark. Great.
So let's let Alan do his thing, and we'll come back to you later after Alan's done.
Thanks.
Okay, so kind of left off where the blockage was, and these generally, truthfully, have only about a 1 in 3 chance of being open because they're so long, all the way down to there. Go to the next. Go to the next set.
Yep.
That's Mike Godwin talking. He's one of our great techs. And that's just a side picture to see where we might be able to go. Go ahead. There's a wire. This is a really soft wire. It's made out of some type of plastic material that we call an eel wire because it's slippery like an eel. So it can go through things that a lot of wires can't. Keep going. And here it was, I think I showed you looped, so that hopefully it won't go outside the artery because we can't really see where we're going at this point. Go ahead. And here we proved that we actually went through the blockage and stayed inside the artery. Go ahead. And these are markers on each end of the balloon. I just showed this, a very long balloon. It's 10 centimeters or 4.5 inches long. Go ahead. Here's the balloon going up. And that's 6 millimeters wide, which 24 millimeters to an inch, just to give you an idea. So a quarter of an inch in diameter. Keep going. And here it is after the first balloon inflation. And Mike, if you could stop there. So there's still a problem up here, and there's still a problem down here. Keep going. So we went down and did 2 more balloon inflations, one low and one, keep going, up a little high. Actually, that's the second one, up a little higher. Next. And that's really the final picture. You can see now he has great flow all the way down to his foot. There's his ankle. So slow. The blockage, well, go back up a little bit. Okay. So the blockage started right under that branch there and continues all the way down till just about where it crosses the thigh bone here. And they'll do great. There is, thanks Mike, that's it. Okay. There's a 1 in 3 chance of re-narrowing from scar tissue over the course of a year, to be fair, whenever we do these balloon procedures, so the patient is cautioned to, if he has any symptoms, he needs to come back and we can re-balloon it. And of course, 2/3 will be fixed at that point. And he'll walk normally now. He's happy.
Yeah, I think he's